Hi, everyone. Today, I'm pleased to be speaking with Elexia Gonzalez Lowe, who is a licensed clinical social worker and psychotherapist in the Austin area. She has an eclectic work history spanning over 18 years of experience, including community outreach, organizing, and direct practice work with refugees, asylees, immigrants, survivors of interpersonal violence. She practices radically open dialectical behavior therapy, or RODPT, and brain spotting. As the daughter of an Asian immigrant and as a 1.5 generation biracial Asian American, Elexia has experienced firsthand the challenges to accessing resources and inclusion in culturally relevant services. So, Elexia, welcome, and thank you for speaking to me today.
Yeah, thank you for that introduction.
So we're talking about trauma today, and this is a topic that interests me quite a bit. And so I wanted to just start off with some basics and talk about the central nervous system and the peripheral nervous system so those listening can kind of understand where we're starting off from. So we have the central nervous system, which comprises of the brain and the spinal cord. And the central nervous system is the place where most of your voluntary movements are coming from. You know, if you're getting up to walk or if you're picking up something to eat, it's where all of the sensory input is coming in and the movements are occurring. We then have the peripheral nervous system where we have our autonomic arm of the nervous system, and that is the place where all of our involuntary movements like breathing and digestion and our pupillary change and all those different things, heart rate going up and down, that occurs. And that's the area that I'm interested in talking to you about, and that's more relevant because that's the place that when we talk about trauma, that is what it generally affects. And so there's a very close link between what we are experiencing from a psychological or a trauma perspective and how it manifests in our body through the autonomic nervous system. So I just wanted to give that background. And, the one thing that you and I, we talk about trauma and like Dr. Peter Levine's work, who is a psychotherapist and or a psychologist and who has worked a lot in the trauma field. He mentions this fight and flight or freeze mechanism, which is something that I found very interesting when I first heard about it. And he gives the example of the cheetah that's chasing the impala, right? And there's generally we think of two options, the fight or flight, whereas what we observe is that something like the impala can actually manifest a freeze mechanism where it's an adaptive mechanism where it can just play dead. Mm-hmm. Although it has a lot of energy in its nervous system and running through, but it can play dead as a survival mechanism. So perhaps the cheetah loses interest or something else, but it can then just get up, pick up, and just run off and then kind of shake off all that extra energy. Mm-hmm. And so there's this freeze mechanism that is evident not only in animals, but also in humans. And so that he relays that because when humans have a traumatic experience or traumatic events, be it a small trauma over time or more larger manifest trauma, they carry all this energy within their nervous system. And what he's arguing is that while the animal can easily dissipate it, the human being, us people, have a very difficult time getting rid of that emotional energy, let's say, and hence we will manifest that later in our lives physically. And that could be whatever physical symptoms that we have as part of trauma. So I think that's a good backdrop to understanding the things that you're going to be talking about. And so I wanted to start with trauma and what you see are more physical manifestations of trauma and how those patients present.
Yeah, absolutely. I think with trauma what we see in brain spotting is the brain is in the body and the body is in the brain. And so everything that's happening to our nervous system, including when our fight or flight systems and our freeze systems are activated, especially when that's happening chronically, whether it's due to stress or being in a toxic or an abusive environment, or having high pressure and not knowing how to cope through it effectively, we're not getting that shake off piece that you're talking about with the cheetah, right? And so I think for us as humans who are an animal species, right, we might be too smart for our own good. You know, we tolerate, we ignore, we say that was nothing, we invalidate ourselves, but we're not allowing ourselves to fully process both brain and body when we've experienced something that shook up our nervous system, so we can actually release it and move forward. And so kind of like what you're describing, we hold on to it, right? We hold on to it in our fascia. Our body is, you know, maintaining that sense of anxiety. And of course, when we have chronic anxiety, that also turns into that emergency shutdown system with depression. And now we find ourselves in this vicious cycle between depression and anxiety if we're not ever actually intervening with ourselves and saying, okay, I just went through something, or I have gone through something, and I need to find a way to get back to that emotional baseline, or allow my body to get back to that baseline so that I can heal.
Absolutely, yeah. And the reason that I bring up this topic of trauma and how maybe it's talked about in some circles, but I don't think it's talked about in the medicine space very cohesively with, let's call it, physical medicine and the things that more medical doctors do, because there is a subset of the patient population that has physical manifestations of disease, or we can call it symptoms. But when you've taken them through all the treatments that you do for other patients that have physical illnesses, or let's say organic illnesses, they still don't get better. And the reason they don't get better is because there is something else that hasn't been addressed. There is a psychosomatic, or there is a psychological reason for their underlying symptoms. And so until and unless we address that, they don't get better. And so it doesn't matter if you're someone who is a mental health professional, or you are a medical doctor and all you deal with is physical medicine, you will run into those patients that have manifestations of trauma coming to you. And so it's very important to at least be aware, at the bare minimum, as a medical specialist, that this exists and how you can go about helping these people.
I think some of those like physical issues that people would probably come to like a medical doctor or space for are a lot of GI issues. I see a lot of people with GI issues that, especially if they have anxiety, you know, the same part of our brain that governs our GI system is the same part of our brain that is involved in our fight or flight, our anxiety. And then also I see a lot of chronic pain. You know, like with that cheetah, if that cheetah is just holding on to that tension in its body and not really like letting it go, then I can see that really developing into chronic pain, and not really allowing the fascia in their body to relax, right? And always experiencing every little difference, or every little like breeze even maybe, as something that's painful, because they're so sensitized to it in that moment. And so those are probably some of the, I mean, of course, like headaches, sleeplessness are also like physical manifestations I hear about a lot in my therapy room, or people who are going to a lot of different doctors chasing these symptoms. And maybe there's even some stigma, like they don't want someone to say psychosomatic. They don't want them, because I feel like they feel like that means that it's all in their head. When, you know, I think it's hard for me to say like, yes, and your head is in your body, you know, like you're not, it's not all in your head as if you're imagining it. It actually is happening. But I think that's the way that they are experiencing that feedback, you know?
Yeah, I think that just like you mentioned, when you use that word, at least from the medical, the MD space, medical professionals, when they say psychosomatic, or, you know, just kind of in your head, you're actually meaning that it's the physical manifestations, because they don't have an organic cause, and agreeably they don't, then there is a tendency to dismiss those symptoms as just kind of coming from nowhere, or coming from your head. And so I can understand how patients get discouraged by that, but I think what the right way is that it might be, you know, it's a valid symptom. You know, you're having GI manifestations, or headaches, migraines, whatever you're having, but there's no cause within that system, you know, that we otherwise see different pathologies. And so from that perspective, I think that there's a reframing that's needed from the healthcare professionals to the patients. So
I agree. And I think that whatever experience or memory or event in their life that tension or that like physical symptom originated from, that's where like the therapy piece goes, where we're like, we need to go back to that and we need to heal that so that we can really allow your system to relax, let it go. Because that is in the nervous system. We're not imagining a nervous system. It actually exists, you know?
Right.
And so one of the ways that we do that, however, is to go back to that original event and see if we can give ourselves that safety that we needed and allow our bodies to now believe that we're no longer in danger.
Yeah. You know, just going back to that initial example of just dissipating that energy, and, you know, us as humans have a very difficult time of letting things go and dissipating that energy like animals do, and just move on from things. You know, it's very difficult to do that. So exactly what you said, we have to go back to that initial event or that initial set of trauma and then heal that essentially. So that brings me to what we were going to mention, which was what we talked about right now, which is the physical manifestations and what we're seeing. And so I think a really good point is that, you know, you are essentially, your practice revolves around seeing these patients with trauma, and so when someone is walking through the door, there's already an assumed trauma because, you know, they're pretty much seeing you mainly for that. But when you take a patient, let's say just anyone who's coming to see me or any other health professional, what are those things that you see more commonly in the trauma space as manifestations of traumatic events or trauma?
Are you asking about like just physical symptoms that might
Physical,
see?
yeah.
Or...
We talked briefly about like GI symptoms, which I see very commonly, but it would be very interesting to kind of discuss about, you know, when we talk about GI symptoms, or even like migraines or whatever physical symptom it is, how do you kind of differentiate between this is more of a trauma-related issue?
Sure. Of course, like if they're not already seeing a medical doctor, just to cover all our bases or make sure that they have a team, because it isn't going to be just one factor, right? We want to, they're all going to be interacting with each other. It's going to become this bidirectional thing, which is that vicious cycle that we get stuck in. So if someone, you know, is treating the medical piece, but not the lifestyle or the trauma or the psychology, then they're just going to continue like triggering that medical like issue, right? And I think it's vice versa as well. I think that we do need to, you know, if we're addressing someone's experiences and their emotions and their motivations and things, we do, in the meantime, not want to suffer too much and also get them to see their doctor. I think that all of it is just going to be with continuing to conceptualize the case and reevaluate. You know, are we making progress? Are we not making progress? As I'm finding out more and more about their coping styles, you know, do they tend to always keep themselves busy, work? They struggle with boredom or silence. Well, I'm kind of like thinking this in the back of my mind as being a factor when it comes to their GI issues, when it comes to their restless leg, you know, or any of those things. You know, or am I finding out that they are dissociating? So this is a little bit of that, a type of freeze response, like they're on their phone scrolling all day long and they really struggle with not having their phone in front of them. I'm going to, if they're coming to me and saying, oh man, like I can't ever get a good night's sleep. My sleep is really disrupted. Well, there's also like this coping factor that comes into play, you know? So how are we coping with our day-to-day stressors? Is it adaptive or is it maladaptive? And those are the parts of the story that really help me kind of like conceptualize that case and understand how much of this is like physical, both, you know, all of the above. What are the things that we can do right now, lifestyle wise, mental, emotional, you know, wise, so that we can not continue making this worse.
Absolutely, yeah. That bidirectionality is so important where, you know, if someone is coming to me or any other physician, we're starting off, looking for physical illnesses and treating physical symptoms. But if we can't make progress there, it's important we don't hit a roadblock, and we can have that in our mind that this could be due to trauma or some psychological aspect, and then we are giving that patient those adequate resources to go and heal that. So it has to be a bidirectional and a very close relationship between the two. Because if you don't do that, then these patients will just go from doctor to doctor trying to get relief. And unfortunately, when they go, each time they go to a new physician, the workup will start again, and they will be put through probably a lot of tests, a lot of waste of time and money, and eventually with no answers. Whereas someone should have just pointed them in the direction of someone like yourself or others who are in the mental health trauma world, that they can address the trauma. But oftentimes, because people aren't aware of that, both on the patient side and on the physician side, then we struggle to get those patients the help that they need in the right time. So,
and of course, there is still that stigma. Like, I'm aware of imagining for a medical doctor to tell their patient, hey, like, you might go see a therapist for this. I would probably putting myself in their shoes, in your shoes, would probably be thinking, oh, they're going to think I'm telling them it's all in their head, or they're going to think I'm not taking them seriously. When really there just isn't enough understanding about how all this works together, that these fields don't need to be siloed, that, what we do and how we live our day to day beyond what we eat and whether or not we exercise and get enough sleep, like that mental, emotional pieces do really also affect us medically. And I think I'm thinking in the medical field, not only patients, but maybe doctors too, are really used to there being an answer, right? It's really used to here's the problem, here's the answer. There's not a whole lot of effort, right? There's not a whole lot of process or journey. Whereas in the mental health field, there aren't clear answers. We try not to go in saying that we know what the answer is, because we know that it's always going to be a process. And so I think most people want that shortcut, that quick fix of just give me a pill and I'll feel better. We don't want to go through the hard stuff and make the effort, when really that would be honestly the shorter path.
Right. I think physical medicine, like you pointed out, is just, a lot of it is based around objective data and trying to get that one answer after doing tests, whatever test there might be, or, that slam dunk. And that's how we're taught in medical school, which is this list of symptoms is this list of diagnoses, and you work through each diagnosis to get the diagnosis that the patient has, label it, and then treat it in this way. So it's very meant to be very accurate and, extremely scientific, extremely accurate, without much of what you mentioned, the journey of it, or, kind of going through that with the patient of experiencing and finding out different ways in which you can help them. It's much less of that. It's let's figure out what you have, let's fix it with whatever modality we have. Whereas the truth is, a lot of patients have much more complex pathology, much more complex stuff going on that modality cannot help with. So definitely agree there. So now, when a patient does walk into your office, what are the different ways in which you're evaluating them and then treating them?
So I'm, of course, always going to listen to my patient and find out what is bringing them to therapy. And so I'm going to find out what is the precipitating event, or what is the problem or issue that you're wanting to work on. How will you know when you're done with therapy, right? So kind of looking at what are the goals and what are the outcomes that you're looking for. And as I'm getting more and more of that story of what how they're experiencing life presently, right? Then that already starts to give me an idea of what it must be like to be in their shoes. And that will start to point me in some directions about what led them there, right? What are all the things that led to this point? What is this your first time seeking therapy? Even maybe there are other times they thought about going to therapy and didn't. What got in the way? So this all gives me information about what they're tolerating, how they're coping, what their limits are. And because I think making that call to see a therapist is a really courageous step that someone takes that they've probably been thinking about for a while. And then, of course, as a social worker, we do what we call a biopsychosocial assessment. And so we'll find out not only, what is your medical, clinical, treatment history, but as well as your families. We'll also find out that, a psychosocial piece of like, what are your relationships like? What is your work life like? Who do you live with? What are the symptoms that you're experiencing that you don't like, that are distressing for you? And how are you coping with those symptoms presently? And so all this really starts to help me conceptualize that case and understand not only what they're telling me and what brings them to therapy, but also starts giving me some clues about what might be some particular, where are the lowest hanging fruit places that we can start? And then what are some stuck points that we're experiencing too?
Okay, that's great. And, I think the part on the biopsychosocial aspect is so important because that's an aspect that gets missed a lot in physical medicine and with a lot of MDs, which is when a patient comes to you, we really don't give that much importance to what is their lifestyle, what is their diet, what is their relationships and what have you. Whereas some of the times the answer can lie in those things. And so we'll be missing a huge piece of the puzzle if we don't get that information.
Yeah. So, and I think even with the patients, they don't often know to provide that information because they don't see it as a problem either unless I ask, like I'll be asking about substance use history, even if it's not causing problems for them. Do they have any self-harming or suicidal urges, or any other risk-related behaviors? Some people don't know that spending a bunch of money impulsively is a symptom, is what I would consider to be a symptom. They might not think I need to provide this information, or they may feel embarrassed about it and also not think that it's a symptom, but it is.
Yeah, absolutely. And so you had mentioned at the start that you do radically,
it's a mouthful, ROTBT, radically open dialectical behavior therapy.
Yeah. So tell us a little bit about that and brain spotting as well. What goes into that? Because I think a lot of people, when they think about mental health therapists or therapists in general, are thinking more, I'm going to sit and talk to someone about my traumas, but they may not be aware that it's not just about talk therapy, but there are all these other modalities that are available, and we have skilled people like yourself in these modalities. So tell us a little bit about that.
Yeah, absolutely. I'd love to, because I think I would love for more and more people to know what the different types of therapies are so they can feel more informed. And right now, doing both DBT and brain spotting, these are kind of really opposite ends of mental health approaches. DBT is a lot more cognitive, whereas brain spotting is a lot more somatic. And usually in the mental health field, we see these different mental health approaches feeling very separate or different from each other. There might even be some opinions out there where some people might think, cognitive stuff is all we need. And some people think, if you don't have the somatic stuff, you're not going to really get the results that you're wanting. And I'm finding that actually you need both. And so DBT, dialectical behavior therapy, and more specifically radically open DBT, which is what I practice, is a type of cognitive behavioral therapy. We are focusing on coping styles, and I'm essentially working really closely with my clients to learn how to be their own behavioral analyst. We're finding out, what are the ways that you're presently dealing with stress. I'm trying to use the word coping because I think sometimes people tune out when I say coping. Especially when it comes to my high tolerance, hardworking, tough it through folks. When they hear the word coping, they're like, I got it, And so, how are you dealing with stress, right? What do you do when you feel stressed? Right. And then as we're looking into that, we find out what happens before, during, and after. And especially when it comes to the after piece, did you get the outcome that you were looking for? And if you didn't, then that's how we know that this particular coping mechanism that you're using, whether it's substances or whether it's spending too much money or whether it's overworking and working long hours compulsively, these are maladaptive mechanisms if it's not reaching the outcomes that you want, right?
Yeah.
If you're still lonely, if you're still depressed, if you're still anxious, all those things. And so when we look at, okay, what were the things that made you vulnerable to make you need to respond in this way? How difficult was it for you to try to delay, using this type of coping mechanism? And then afterwards, what happened? How did you feel? Right? How did you feel about yourself? Did you feel worse? Are you really keeping yourself in this stuck place in the long term because you're just kind of putting a Band-Aid on it over and over again?
Right.
And so that's the DBT. More specifically, radically open DBT, we're looking at more perfectionism, rigidity. This is also going to be your eating disorders.
People pleasing. Don't forget
people
that.
pleasing, absolutely. Yeah. And I would say, like earlier when you were mentioning fight, flight, or freeze, I would put people pleasing kind of in a spectrum with the freeze responses.
Right.
That's when we are dissociating from how we really feel, what we really need, and whether or not there's actually danger or threat occurring around us, because we're just trying to stay in the good graces, right?
Right.
We're trying to avoid discomfort, essentially.
Avoid conflict as well.
Exactly, avoid conflict. And so is that a coping mechanism that someone's using and that's keeping you from your long-term goals in your life so that you can feel happy and healthy and well, And so in Radically Open DBT, we're looking at some of those harder to treat, the more treatment resistant, disorders or, symptoms that we might see in the therapy room, because there is some type of rigidity there. Something is not moving for that person where they're not able to receive or be flexible with the treatment. And so we're finding out more, like, what is that internal piece? Is there a rule or a core belief that's keeping you stuck? What are the things that no one's been able to identify with you, or that you've been too embarrassed to share, or that you've been ignoring yourself? And so it is very deep work in that sense, but it's still very cognitive. We are practicing mindfulness, but not as deeply as what a somatic therapy would, like brain spotting. And so brain spotting is working very closely with the nervous system, like you were talking about earlier. While in DBT, we become familiar with all of our emotions and the actions that they give us, like their urges that they give us. In brain spotting, we're looking at, we say where you look affects what you feel. And so we are using the gaze where we look. And basically, there is actually more research around this that I've been seeing pop into my feed, that where you look gives you kind of a direct line to where that memory or that event is stored in your subcortical brain. And your subcortical brain is a limbic system where all your emotions and your memories live. And so we kind of imagine it, we call it a brain spot, because we kind of imagine there's like a spot there that holds all the different components of the emotional experience that you went through in that previous memory. So not only where were you looking, but like, what did your body do? Where did you tense up? What did you feel? What did you think? How was your breathing? Like, all that stuff is stored in that space.
Right.
And we have more direct access to it depending on where we're looking. And so we use that to help that person heal. We use that by finding that access to where it's stored in the subcortical brain so that we can heal it.
That's so fascinating. I think that even myself, being in the healthcare field, I just wasn't aware of all these different modalities that are present for patients that they can use for healing their trauma. And, we just, again, think of therapy, even myself think of therapy as talking. And sometimes, you can get discouraged by that, because it just sometimes could feel like, I don't necessarily just want to be talking about this with someone and reliving those past traumas without actually healing them and fixing them. And so I'm very excited that these modalities exist and that, you're using them. So that's great. And so I wanted to end by asking you what you felt are the biggest barriers for people accessing mental health care resources and trauma care resources. I think that you had mentioned earlier about stigma. And that's something that's there, and maybe it's getting a little bit better, but it's something that's going to be there from, there's many generations of stigma for many reasons. But what are other more real or, down to real out there issues that you see people experiencing when it comes to mental health access?
Yeah. definitely the stigma. And if we were to put additional words on that, I think that there is embarrassment and shame sometimes as well. Not only about going to therapy, but also about having to share their story with a stranger, essentially, until you get to know each other better.
Right.
And I think that some of the other barriers I see is definitely folks who are very high achieving. They've been dealing with it on their own for a really long time already, as it was. And they're wondering, like, do I need to, when do I need to, or do I ever need to have additional support here when I've been doing it on my own for so long? And I think that when you're the person that's on the inside of that experience, it's really hard to tell. It's really hard to tell when it's time to reach out and ask for help. And there might even be some internal myths about, like, well, what can a stranger do for me when I know myself better? What could they offer me that I didn't already think about? Because I'm already a big thinker. I've already analyzed everything.
And so there might
exactly, I have all the answers. So there might be a little bit of that of I'm too smart for my own good, which is like a good thing. These are the folks who are very high achieving and they're able to accomplish a lot, but then we don't know when is it okay to feel that way. Like, when is it adaptive or when is it maladaptive to have that perspective? I think also it's scary, to go into therapy. We know that that's probably going to bring up difficult stuff. So there is that fear of discomfort and conflict again of, like, okay, if I'm going to do this, it's going to be really uncomfortable and hard. Am I ready for that? I'm already lacking energy in my life. How this is going to really be continuing to exhaust that, not really also imagining however it's going to restore it instead. There is going to be difficult moments, but that there is the reward. I think also maybe someone isn't able to organize themselves enough to get themselves to therapy. So if they're engaging in a lot of substance use, if they've really filled up their life so much that, especially with the people pleasing, that there's no space for them to focus on themselves, or that they're so disorganized with, really uncontrolled, coping mechanisms, then it may be difficult and they may really need someone to just direct them and take them somewhere. And then, of course, the one that's difficult for me is the symptoms that's bringing me to therapy may show up in the therapy room towards me, right? So if we're, a lot of times in mental health, we consider alliance ruptures, like these ruptures, to be real opportunities for healing. They really get to see something from their personal life showing up in the therapy room. And if there's enough trust and rapport, then we can deal with it directly and we can really talk about it and get that healing and validation that's needed so that they can start replicating that in their personal life. But it doesn't always go that way. And so I think there can be some fear of that happening, or when it does happen, maybe they prematurely discharge from treatment, which in my mind, that's still a part of the process.
Right. All those are such great points on all these barriers that we have, both internally and then some external as well. Like you mentioned, the disorganization, or, perhaps unable to afford to get to a therapist, not having insurance, and all these different barriers, or living in a place where there aren't many mental health therapists. That's another issue. So there's all these real life barriers, and I think there's a lot being done to try to break these barriers, but at the same time, we are falling short as well. So there's a lot of room for improvement, but I think it's just so important, because I'm coming from a place where I see this fairly regularly as well with people. And also just how interesting a topic this is, that I think it's just needs more awareness, both from the healthcare, the physician and healthcare side, but also the patient and the layperson side. So, I'm glad to be having this conversation, and, thank you for doing what you're doing and fighting every day to get these patients better. So thanks for that. And thanks for talking to me about all this stuff.
Yeah, thank you for having me. It was a really great conversation. So much more to say about it, but it's always fun.
Yeah, and when there's more updates, I think we should definitely have another conversation on it.
Okay, I'm down.
So awesome. Okay, thanks again, Elexia.
Yeah, thank you.